I'm ready.
So the topics were toxic inhalation. That would be like burns, smoke inhalation, carbon monoxide poisoning, aspiration, near drowning, hypothermia. Hey, Taylor. The next one was indications for non-invasive positive pressure ventilation. That's Kempinen. And then invasive ventilation the next week, Kempinen. And then the next week after that was the NRCC, but the week after that was the neuromuscular disease presentation by Kim, Dr. Kim. And then the last one was Kempinen supportive care. So there's 5 there, 5 lectures. So that's what was covered. And so let me go through and see what we got. So, they always have a lot of these, clinical scenarios, patient scenarios where they give you, patient data, blood gases, temperature, vitals, et cetera. You have to go through, sort through them and notice the abnormals and decide what to do about a patient. There's usually something really apparent in almost all of those, that's, that has to do with the topics of the lecture, for example. So, one of the lectures this time, for instance, talked about supportive care and, pain management and so on. So you might be looking for, that kind of thing in the clinical stories that you see on this exam. So that they would, that would be part of the list of problems that you need to identify, what would help this patient situation mostly, from that standpoint. So, but he also did, they also did mechanical ventilation. So of course you get, questions that give you ventilator settings and ask you to make modifications in the ventilator settings according to the blood gases. So that would mean that you, for instance, need to consider PEEP, mode, FiO2, tidal volume or pressure, and frequency, but according to the mode, depending on the mode, given a blood gas. So, but also take into consideration when you do those kinds of questions, the patient's diagnosis. That can have a lot of impact as to whether you're going to be concerned about auto PEEP, for instance, on people that have trapping, and also, for example, whether you're going to increase the PEEP or whether you're going to increase the FiO2 as another possibility. So you do have to pay attention to the patient's diagnosis. So you see something like severe COPD, you should be thinking about trapping, air trapping. But you have to kind of work through the choices that you're given too. So it you may not be able to find the exact choice that you'd like to on a particular patient. The NBRC test is like this too, where you maybe like not to raise the PEEP, you'd rather raise the FiO2, for example, on a guy. And you might clinically do that, but you're not given that choice. So it's a multiple choice question. So you got to go with what's there. So pick the best answer, right? Okay, so be sure you pick the best answer. Okay. And about pain management, there's types of drugs that are used to be anxiolytics or anxiety drugs. There are delirium drugs and pain drugs, right? And paralytics and be the other category. So what you want to be able to do is name the drug and put it in one of those categories. So that you know that this is for anxiety, this drug is for anxiety, or this drug is for pain relief, or this drug is for delirium, right? So look at that list of drugs that he gave you there for that. Okay, so here's a question about indirect calorimetry. So this is a device that measures the oxygen consumption and CO2 production, and the way it does it is what you need to know. How does it accomplish this? So what it's doing is it's looking to try to give us numbers for oxygen consumption based on what the patient inhales versus what the patient exhales, right? So the difference is how much they consumed. That's O2 consumption, right? And CO2 production is the same way. how much CO2 do they inhale versus how much CO2 do they exhale. And from that, they derive caloric, because the metabolic rate is related to the oxygen consumption. They can get the caloric output, the patient's caloric output from that. And so how do they do this? I basically just told you. They monitor in and out CO2 and O2 and minute volume, and they can extract from that metabolic rate and calories, and also they can extract the kind of feeding that the patient should get. So that should they have more fats, or should they have more carbs? So what kind of things should we feed them? Because what we're doing is we're trying to design the total parenteral nutrition of a ventilator patient, a long-term ventilator patient, to support them, their nutritional needs, without producing extra CO2 and making them work harder breathing. Anyway, this device, though, is very sensitive. It's very sensitive, and you have to have, well, first of all, you have to have a very stable FiO2. That's one thing. But another thing is that the patient's settings have to be very stable, very stable. You can't have, patient can't be changing a lot when you're trying to measure the metabolic rate. So it's really important that you realize that if you've just made ventilator changes, for instance, that you can't do a metabolic study very soon. You have to wait for them to stabilize into that new set of settings before you can do the metabolic cart measurement. So you need to realize that respiratory quotient. Respiratory quotient is O2 consumption and CO2 production. The number is called respiratory quotient, right? And the respiratory quotient tells us whether we're overfeeding the patient or underfeeding the patient. Do you remember this? So that's what this next question concerns. So he gives you a respiratory quotient and asks you to decide whether the number of calories that we're giving the patient is too many or too less, too little. Okay, so then this next question, he must have covered trauma in there too. Did he cover trauma? So this question's about rib fractures, traumatic rib fractures. And so take a look at the notes on that. I guess I'm sort of thinking you need to know the anatomy of the chest in order to understand, which ribs are where, what the ribs are over, and what could be injured by traumatic rib injuries. So, basically lower, especially on this side, is liver and spleen, right? And they're real bloody organs, and when they get pierced there, a lot of blood loss in the abdomen. And then back here's kidneys, So those are the lower ribs. The upper ribs, more likely you're going to see things like pneumos up in the upper part, so if they have upper body breaks. And then flail chest, another thing. So, and back to nutrition here. So, so the typical mix of total parenteral nutritional mix. What's the typical mix got to be? What should be administered to the patient as far as parenteral tube feeding, not tube feeding, parenteral feedings. What's the mix of? Right? You don't need to be specific about this. Just how do we start? Oh, actually, you don't start with the total parenteral nutrition, do you? Right? You start with an NG tube, right? So what do we usually put in the NG tube in terms of the mix of proteins and carbs and fats? No, you don't need to be specific, but it needs to be a mixed, in other words, a mixed diet. is what goes into the tube feedings in the beginning. And then from there, what you do is you design their subsequent feedings using the metabolic cart to decide if you're overfeeding them in any of the categories. Carbs and fats especially come up. Okay, so the signs and symptoms of carbon monoxide poisoning, cyanide poisoning, also the clinical situation that goes along with cyanide and carbon monoxide poisoning. So, for example, if you found a person in a garage with a car running, that's an obvious one. I hope you'll know that's carbon monoxide poisoning, right? But she's also got chlorine gas, phosgene, and ammonia, and sulfur dioxide, and nitrogen dioxide on here. It doesn't look like the questions are very specific about those problems, but they're also toxic inhalations. And I don't know. I'll look further down the thing here. And then how do we diagnose those things? Especially carbon monoxide poisoning, we run into that a lot locally. How do we diagnose that? Okay, this is about head injury and where in the spinal cord, if you experience a break in the spinal column, what systems will be affected, especially when will the respiratory system be affected. That would be something to think about. Okay. And the symptoms of neuromuscular disease, the respiratory symptoms of neuromuscular disease, what are they? And how do we monitor patients with progressive neuromuscular diseases? Or, some of these neuromuscular diseases kind of come and go, like myasthenia gravis. How do we monitor the patient to see if the patient's experiencing a crisis with their neuromuscular disease? So I'm hoping that when you answer this question, you'll be thinking of measurements that measure the pulmonary function measurements that measure strength and stamina, say, for instance, rather than total lung capacity, which would be a thing that you'd want to measure in a patient to see if they have air trapping, right? So you need to use your common sense about what do you need to know with a patient with neuromuscular disease, right? And that's, are they going into basically hypoventilating? Are they hypoventilating or hypoinflating? What are the measurements for that? Well, total lung capacity is not, for example. And so you've got Duchenne's muscular dystrophy, myasthenia gravis, Guillain-Barré, spinal cord injury, and stroke to sort of think through, patient scenario. So you're basically given a patient scenario and asked to try to identify which one of those neuromuscular diseases she's got. Okay, the next question is about pulmonary fibrosis versus respiratory muscle weakness. They're both restrictive lung diseases. So pulmonary fibrosis is a restrictive lung disease, so is neuromuscular disease. But the difference is in the pink stuff in the lung, that's where pulmonary fibrosis is in the parenchyma of the lung versus chest wall and the musculature of the chest wall. So how do you differentiate between those two restrictive lung diseases? And in particular with respect to the pulmonary functions and residual volume changes. And what's the minimum vital capacity for a patient that has acute respiratory muscle weakness, like from myasthenia gravis? What's the minimum vital capacity? where they need to be intubated and ventilated.